Hello, good afternoon, doctors. On behalf of Hetero Healthcare, I, Dr. Prashant, welcome you to this webinar on Carbetocin in action. Doctors, as you know, at Hetero, we market products in different therapy areas, like in gynecology, orthopedics, derma. We have a strong support, R&D support, and we have developed many unique formulations keeping patient benefit in mind. Recently, we have introduced Carbetocin. Carbetocin, as we all know, is used for prophylactic management of PPH. PPH is a condition which can lead to a disaster. Whilst there are several papers and guidelines which suggest the use of Carbetocin in PPH, prophylaxis of PPH, we have eminent speakers today with us to give us insights into their experience with Carbetocin. Today we have got a panel. We welcome Dr. Kishore Pandit. Dr. Kishore Pandit is MBBS DGO, Fellowship in IVF UK, Diploma in Laparoscopy Germany, Training in Office Hysteroscopy Italy, Training in Pelvic Endometriosis and Laser Surgery Austria. Sir is visiting laparoscopic surgeon, BJ Medical College and Sassoon Hospital, Pune. Founder, trustee, secretary and medical director, AIMS, Pune. Director and IVF consultant, the Birth Company IVF Center, Pune. Sir is founder, president, Pune Association of Gynecology and Endoscopic Surgeon. He has won a Top Gun Award for fastest laparoscopic endosuturing, San Diego, and has published correlation of endoscopic interpretation of endometriosis with histological verification in European Journal of Gynecology. Case report on silent uterine rupture in Scholar Journal of Applied Medical Science. Case report on corpus luteum cyst rupture in Juniper Outline Journal. Original research article, Laparoscopic Hysterectomy by Pandit's 4S Technique, a case series of 3,011 patients in Scholars Journal of Applied Medicine Surgery and Science. Welcome, Dr. Kishore Pandit. Welcome to this webinar.
Thank you.
The next speaker, Dr. Meghana Argade. Madam is MBBS DGO with fellowship in ART, cosmetic gynecology and obstetrician since 20 years. Madam is fertility consultant at Gyne Hospital, at the Gyne World Hospital. Welcome, madam. Welcome to the webinar. The third speaker is Dr. Neha Kulkarni. Madam is consulting anesthesiology for past 29 years, member of AOA, specialized in obstetric anesthesia and labor anesthesia. Madam has carried out HPV vaccination and cervical cancer programs, awareness programs, released audio podcast about importance of anesthesia for general population. Madam is avid trekker and has done 12 Himalayan treks and many treks in Sahyadri mountains. Phenomenal, madam. Welcome, Dr. Kulkarni, to this webinar. Welcome all of you. And over to Dr. Kishore Pandit for further deliberation. Thank you.
Hello, good afternoon, all of you. Today we will discuss the new molecule. I would say new because it has come into the market in last 4 years and picked up by various companies in last 2 to 3 years, and which is definitely beneficial for us, you as a gynecologist, obstetrician, because the important scenario in our practice is PPH, and it is very useful in controlling the PPH. So here we will share our experiences. We have selected 3 cases to tell you exact what is the application and how that molecule benefited our patients. So would you like to start, Dr. Meghana, first?
Yes, I'll tell one case of normal delivery. She was a primary gravida, 29 years old patient, and she was conceived naturally. She came to us for induction of labor because she was post-dated, 40 weeks, 4 days. We did her assessment. Her cervix was closed, os was closed, and cervix was posterior. So we decided to induce her with cervical installation. Cervical installation was done at 5 p.m. in the evening, and she progressed gradually and she delivered vaginally at around 4 in the morning. After delivery of the baby, we gave injection Carbetocin intramuscularly. And after that, placenta was expelled completely, uterus was well retracted, and the bleeding was less than 500 ml. And we did not use any other uterotonic agent, and the case was very well settled with single dose of Carbetocin.
So how much was the blood loss, you say?
200 to 300 ml.
Okay, which was not very significant. Okay, and why you say that you wanted to use Carbetocin whether you were accepting or expecting some PPH in this case.
No, actually, this was plain case without any complication. So we were not expecting a PPH, but we just used it to prevent the excess bleeding.
Okay, so this was, you said, slightly 4 days overdue, right?
Yes.
So, do you find any increased chances of PPH in such kind of cases?
Yes, slight increase in PPH is there.
Okay,
And when
so
we
that's why
reduce the
you.
case, yes. When we reduce the case, there is chance of PPH.
Okay, right. So, you mean to say whenever we try to induce the patient, which is not going into spontaneous labor, they may have a slight increase incidence of PPH, and there, if you expect PPH or more bleeding, then you would like to prophylactically carbetocin should be added. Okay, fine. So, yeah, Dr. Neha, what are the challenges you as an anesthetist face during cesarean section, or maybe where painless labor? So, do you want to give us some case study or some case which you attended and where you prevented by giving carbetocin? Or
Yeah. So, during normal delivery or during planned cesarean sections or emergency cesarean sections, or the sections which happen after epidural analgesia sometimes, or even normal delivery after epidural analgesia, we know that nowadays patients are overaged, means they conceive around after 25 years of age or around 30 to 34. So they are elderly primaries or elderly patients. So they, along with that, they have comorbidities. And even though they don't have comorbidities, even the previous history or her anemia status or other problems. So there is always a chance of PPH. So we already well equip ourselves or the setup with all the things which are required to maintain the hemodynamics in each and every case. So first thing I like to emphasize over here that we require a very efficient team always to manage any even simple normal delivery case. So I will always say this, that we should be well equipped with all the drugs and particularly uterotonics, because one of the major causes, major problem which do occur after normal delivery or cesarean section is postpartum hemorrhage.
So you mean to say we are always ready to tackle when the PPH happens.
Yes.
But now because of new drug has come, I think we can prevent PPH.
Yeah, so prophylactic use of various drugs. Now we are so fortunate that the inventions are going on and we do get newer drugs. So this drug, Carbetocin particularly, I'm using for last 2 years. Before this companies, previous other companies were also in the market, and we just use it as an experience. But I personally have a very good result because of Carbetocin use to prevent PPH.
Okay, so do you like to tell us one case?
Yeah, one case I will definitely put forth here was the case the patient was, I already said, she was a second gravida, she was 34 years old, and she had a history of previous cesarean section. But in that cesarean section, she has faced postpartum hemorrhage. So it was not done at our place, it was done at some different place, but it was well managed by that team, and she was good afterwards. It was uneventful afterwards. So this was the history. Now she, along with that, she had GDM also, and she was 37 weeks of the pregnancy, but baby was big, it was microsoma, and along with that there was polyhydramnios. So the gynecologist here decided to do a planned cesarean section. So expected weight of that baby was around 3.5 kilograms. So in this case, I had given spinal anesthesia, keeping everything ready, all the drugs were ready. And after the baby's delivery, I had given intravenous 100 micrograms of carbetocin slowly over 1 minute. So this I decided to give carbetocin in this case because she had previous history of postpartum hemorrhage. And I had not used pitocin in this case, only carbetocin. And after carbetocin, there was good retraction of uterus, and
Yes.
the bleeding was almost around 450 to 500 ml.
That,
not
that
more
means
than-
there was no PPH at all.
Exactly.
Okay.
And after that, I didn't use any other iteratome in this case because it is not required. Generally, we do give pitocins, apropitocins, and we do give lithargine. In this case, we keep ready carboprostols, prostaglandins. But in this case, I used only carbetocin, and that it prevented PPH. So this was my experience.
Okay. That means where the patient had a history of previous postpartum hemorrhage. In that patient, you have just given carbetocin and it was well retracted, and you could avoid the PPH in this delivery. Okay. And can I ask you one thing? Why you have given intravenous and not intravascular?
Yeah, now keeping in mind her previous history of PPH, see, when we give intravenous drug, actually insta-strings, like within 2 minutes it starts its action. And there is, because of carbetocin, literature has seen, is told
The
that
action is immediate.
immediate
action.
Tornico effect, like the myometrial vessels are contracted well, they are, squeezed between, and so that there is less bleeding. So immediate action comes, and we could avoid, and there was a big baby, so it was an overstretched uterus there. And she had again complication like GDM. So she was really a complicated patient, so wanted to avoid PPH as early as possible. So decrease blood loss, and so recovery is also fast because of all this.
And I guess this patient must have been on insulin or
Exactly.
some
Exactly. So she was well controlled on
well
insulin.
controlled, yeah. But still, the baby weight was slightly
Yeah, it was
higher.
3.5. Yeah.
Was she having polyhydramnios also?
Yeah,
Yes.
she was having polyps. These are the causes which cause uterus stretch more than the normal limit. So there are chances of otonio.
So I would say this delivery, she had double the chance of PPH than her previous,
Exactly.
because the age also is advanced.
Yeah.
GDM.
Yes.
Okay.
Keeping in mind all these things.
You had given carbetocin.
Yeah, because main cause of PPH, 70% of the cases, it's uterine autonomy because of various reasons. So main reason is overstretching of uterus because of various reasons, various causes like a big baby, twins, or previous history of, there's so many indications to give carbetocin in certain cases. So one of the reason is overstretched uterus. So I had thought of giving carbetocin in the first place.
Dr. Meghana, would you like to add something that if at all carbetocin was not available, then what would have you used or preferred to use as a first line of treatment?
First line of treatment, I would have used oxytocin drip, and then I would have switched to misoprostol.
Okay.
And if necessary, I would have used carboprost.
Okay. I think when this might be your thought over it, but I think I would have used carboprost at the first go if carbetocin would not have been there, because she had a previous history of PPH, and it's better always to avoid any complications, and she was having GDM also.
Yeah.
Okay, fine. So now I will tell you a third case study where we have used carbetocin. As an IVF consultant, most of the deliveries are C-section deliveries. and we usually plan around 38 weeks. So, and these IVF patients, that means infertile patients, are usually above the age of 35, and comorbidities. And in such cases, there is always a chance of postpartum hemorrhage and some other complications also. And they are very cautious about their own health and baby's well-being also, because it's a precious pregnancy. So we have to be ready in all the aspects. So baby, we try to take care by delivering them at where the pediatrician neonatologist is available. And for the patient, we should think about postpartum hemorrhage, and accordingly we should take a prompt action, and we should have to have some protocols wherein we try to avoid PPH. Yeah. So this case, she was 36 years of age, primary gravida, and she was having twins pregnancy. 10% IVF pregnancies are twins pregnancies. So she was twins pregnancy, and there was fortunately no other risk factor. And after 37 weeks, around 38 weeks, we planned to deliver, and elective LSCS was planned. Spinal anesthesia was given, and after the delivery of the second baby, injection Carbetocin was given intramuscular. And placenta was expelled completely, uterine tone regained quickly, and significant reduction in blood loss. So we were expecting that there will be some blood loss, because she was not into spontaneous labor, and chances of PPH retraction would have been slightly delayed. And there is always a manual removal of placenta. So, and twins also. So that's why we were expecting that there would be significant blood loss. But because of Carbetocin, we haven't faced any kind of heavy bleeding or any PPH. So, and fortunately, there was no need of giving any other adjuvant or any drug to that patient to control the bleeding or atony after giving Carbetocin.
This was planned.
This was a planned.
We have not used anything for induction, planned section.
Planned
Cesarean.
cesarean section, yes, at 37, 38 weeks. Yeah. So, yes, Dr. Prashant, how would we go
Yeah,
ahead?
now nice inputs, it's very interesting. Especially, we were not aware that, I mean, when the patient is post-date, the chance of PPH could be more. I mean, this is something new learning for us.
Yeah, because what happens is, she doesn't go into labor, that means something
Correct.
is wrong.
Correct.
Something is not
Very interesting,
normal,
yes.
something is not happening normally. So there you should always think of
Absolutely.
PPH. Yeah.
Priyanka, can we move on with the questions? I mean, you all have shared your experience with Carbetocin, but otherwise, any specific point you want to make about your experience with Carbetocin?
Any
I mean,
Any
regarding
specific-
onset of action or regarding force of contraction, regarding frequency of contraction, anything?
Yeah, we have always in literature we have read that causes stable and rhythmic contractions.
Yeah.
It's very important because other than Pitocin, Methergine or Carbopros, they are not rhythmic. They're what should I say?
hypertonic, you can
hypertonic.
say.
Yes,
Yes.
correct.
That will give complications. That will lead to complications.
That's right.
That
So it's very may lead to
yeah.
complications. So the stable and rhythmic contractions because of Carbetocin is a very important point.
Yes.
Second, I would like to add that the immediate action.
Correct.
If you are in emergency and if you want
Yes.
an immediate action, you can give it IV and immediately the
Yeah.
contraction.
And
And single dose again.
Single dose.
rather than the drip.
Long lasting. It's almost 1.5 hours the action
Yes.
remains. And many times there is no need to give other uterotonic.
Ah,
Many
yes.
times.
Yes.
So we can avoid uterotonic like carboprost, prostaglandins.
They themselves have their own side effect. I mean, every drug will have its side effect. Yeah.
Exactly.
On a lighter note, I want to add one thing.
Yes.
The doctors or obstetricians who are in love with oxytocin, so if they like to use the oxytocin, they can use it even after giving carbetocin. That's the beauty of it.
Correct. And in the interior, single dose will matter in the interiors of our country where there may not be facilities for IV, etc. I mean the technical help.
Correct.
And it is said to be more stable in terms of temperature. Power outage is a problem everywhere in cities also. And maintaining that cold chain is difficult for oxytocin.
Yeah.
That is not
So
required.
one thing, because we have discussed this molecule or drug whenever we have a round table meet and
Correct,
whenever we
correct.
friends meet. So some of the doctors or friends, they share that the slight hesitation is only because of cost. So I don't know
Correct.
whether it should be a hindrance. I don't know. I completely don't agree with them
Cost,
that why they should
yes.
think.
But then the advantage and the benefit and the patient profile, where it would be useful.
Yeah, but I don't know how much is the cost. Would you like?
Can you help us? What is the cost?
It's not significant, I guess.
Not significant.
It's
I
not
mean,
significant.
yes.
So yeah.
And looking at the life-saving potential of these type of drugs, we really
Yeah,
don't. Yes.
absolutely.
Next
So
question.
I think whenever somebody tries to explain about carbetocin, we should add this point also that
Correct.
cost is not much, and even if it is there, it doesn't matter at all in the
Exactly.
long.
Looking at the benefit, ultimate benefit.
Yeah.
In my life, I had seen only one case of PPH.
Oh.
I mean, I'm talking about the late 70s. You can imagine there was only one drug, oxytocin, and of course, methyl ergometry. In JJ Hospital, we had, my God, one case, and then the whole gynecology department was
shaken. Yeah, absolutely.
Yes.
And that one case is good enough to remember for your lifetime. You have seen this in 70s and still you remember.
But the patient came smiling, delivered, and then bakta, she went into that shock, and I mean, what it was.
Yeah.
But by God's grace, she was saved.
Yeah.
Next question, Priyanka. Which patient profile where doctors can anticipate PPH? I think we expect the unexpected is the theme of our profession.
Correct. Absolutely. Dr. Meghana, would you like to do this?
Can you answer?
When the uterus is overdistended, then we can expect PPH. Like if there are twins, if the patient is diabetic and it is not controlled, so the baby is macrosomic. If there is polyhydramnios, all these cases may lead to PPH. Again, if there is previous history of PPH, then there is double chance of PPH in the second pregnancy.
Okay.
If there is previous cesarean section, if the patient is anemic, this also can lead to, and if we want to reduce the chance of blood loss, so we have to anticipate PPH in these situations. If the patient is obese, if there is fibroid in the uterus, then also there is chance of PPH. So we should anticipate PPH in all these cases.
Hypertension predispose a patient. Hypertension or predispose a patient to PPH.
Yes, hypertension also. But I don't think we can use carbetocin in hypertensive patients or
epilepsy, because there is no data available, they say. But one thing I will like to add is many patients are on magnesium sulfate. So magnesium sulfate is a uterine relaxant.
Correct.
So if the patient is on Maxil, then there is a problem with the retraction. So in that case, we can use carbetocin.
That's very important thing.
Many times patient comes as an emergency section, sometimes there is respiratory distress or something. And then GA is given, general anesthesia is given many times, keeping in mind all the contraindications and all. So if we give general anesthesia, then the uterus is relaxed.
Relax. So again,
in this
predisposed
case
to
also,
PPH.
again, yeah, bleeding, and so we can, in these cases also, we can use Carbetocin.
Next question, Priyanka. When would you actually prefer Carbetocin over oxytocin for prevention of PPH? In which specific patients? You all have described the profiles, but any specific, like we'll never think oxytocin, straight away go for Carbetocin.
The patients who are subjected for planned cesarean section and the patients where prior oxytocin induction was not used.
Exactly. So endogenous and exogenous oxytocin is not given not with the patient, available for the patient. So the receptors are not exposed to oxytocin.
Oxytocin.
In that case, Carbetocin will be 80% bioavailable for the uterus to contract. And so the maximum efficacy will be seen. So in that case, we prefer Carbetocin.
I think for every planned cesarean section, we can
Yeah.
prefer Carbetocin.
Correct.
Yes.
Yeah.
Most of these questions are overlap, but then these are
Yeah.
questions which actually come from field. Can we use now? This is a very important question which had come. Can we use Carbetocin in case of retained placenta? Of course.
I don't think we can use Carbetocin in case of
Yeah,
retinal
if os gets closed, then there is.
Placental pieces and then only we should use.
Correct.
Not
Yeah. No, but what happens usually we give Carbetocin or any methargine or carboprost once the baby is delivered.
Exactly.
So this cannot be used for retained placenta. That means once the baby is delivered, whether you have given Carbetocin at that time, if given, then definitely you cannot use. If oxytocin is used or methargine is used and still the placenta is retained, then I don't think Carbetocin can be used. Because there will be a
hypertonic action, and first we'll remove the placenta. We'll take out the retained
pieces.
placenta,
And then
we'll think what to give.
So os should not happen that os gets closed.
That only, no? That after removal of the retained placenta, then whether we can give.
Then it's possible. Then it's, that's a normal case. Yeah.
Yes.
Next question, Priyanka. This is another question which has come across country. Some doctors said yes, some doctors said we have no experience. What is your?
I think there are no studies because
There are no
can we
studies.
use
There are no
Carbetocin in
studies.
RH negative mothers? So there are no studies on this. So and we also don't have a first hand experience
Correct.
in RH negative mothers. So we really cannot comment on this.
Next question, Priyanka. Can a doctor use Carbetocin? Sir, you have just answered this. Can a doctor use Carbetocin for prevention of PPH if oxytocin is used for labor induction?
No, we cannot use. We cannot use because the
Receptors are already.
receptors are already blocked.
Now, this Carbetocin can be given by IV and IM. Is there any such thing that in these cases you will use IV route and in these cases you will use IM route? Or generally we prefer
emergency where blood loss is more and anticipate PPH.
The only advantage of IM route is possibly the duration of effect remains slightly longer.
Slightly longer.
In normal deliveries, that anesthetic is not there. So when you give IV, anesthetic should be there.
Okay.
So that if there are any problems, and if previously Pitocin is given and again a Carbetocin is given, there is drug interaction, and there are many cases of cardiac arrhythmias, bradycardia, tachycardia. It's given in the books, but the team should be, well trained and all.
Now we'll start calling anesthetists for normal deliveries also. That's what she meant to say. Yeah, but no, where the blood loss is, whenever there is emergency, we can give IV. Even if anesthetist is not there, we can give IV. If you are experiencing more blood loss, because the only thing is mechanism of action is immediate. And you can control, and you can control the blood.
And in IV, in PPH, every second will matter.
Yeah, absolutely. Absolutely. Every drop of blood is important, whichever you can say.
If patient is not responding adequately with carbetocin, which can happen, what additional uterotonics you would use?
I think we can use all the other which
yes.
are being used since ages. So we can use prostaglandins also, we can use oxytocin also, we can give methargine also.
Methargine also. Methargine side effect of hypertension, is it very high frequency?
See, usually in hypertensive patients, we don't
Avoid.
like to use, yes, we avoid. But we can use carbaprost, yeah. Carbaprost.
I mean, we can use all the drugs that we have been using otherwise.
Yeah, she said one good point that we can use methargine, but it should be given intramuscularly, not IV.
Correct. Ah,
In
intramuscular.
hypertensive patients, yeah.
That's very interesting.
Yeah, yeah.
Next question, Priyanka. The advantages over other drugs, oxytocin, misoprostol. Between misoprostol and carboprost, which is used more commonly?
Misoprostol is used
Used more
commonly, and in I think in rural areas, methargine is used more judiciously, yeah, more frequent.
The side effects with misoprostol or carboprost?
Misoprostol, I don't think there are any side effects. Yeah, very minor side effects.
And carboprost also? Nothing major.
Carboprost and methargine, I would say that vomiting and nausea, vomiting is more. Oxytocin, there is no side effect as such.
Yeah, as such.
Yeah.
Sir, have you seen that retention of water or ADH effect with oxytocin anytime?
Yeah. Hyponatremia is seen.
Hyponatremia.
Because it
Seen,
competes with the vasopressor
Yeah,
receptors.
Especially possibly if you have a longer drip or a longer prolonged
Yes.
labor.
Yes.
Yeah.
Next question, Priyanka. Should carbetocin be kept as reserve drug or it should be used as a first line?
There will be vote of yeah. So I would say that yes, it should be used as a first line.
First line.
What would you say?
Exactly. One point I would like to add, I read this because in WHO, in emergency essential drug list, they have put carbetocin.
Carbetocin, correct.
So WHO has done this. So I think it's a first line drug.
Well, that's very important point. Yes, correct. Yes, Priyanka. How would you compare adverse effect or contraindications of carbetocin over oxytocin and other uterotonics based on hemodynamic profile or other side effects?
I think oxytocin is safe in lot of patients. Carbetocin has some limited patients where we cannot use, like in hypertensive patients, cardiovascular compromised patients, history of epilepsy.
Serious diseases, cardiovascular diseases, we cannot use carbetocin because we have not studied that molecule that much.
And previously used oxytocin, that is induced with
The receptors
oxytocin.
would be blocked. Yes.
There we cannot use. Would you like to add something? So the contraindication, I mean to say, to use.
If the patient is allergic to oxytocin drugs previously, we cannot use.
Yeah.
Even patient with renal diseases and liver diseases,
Hepatic
we
impairment.
use carbetocin very cautiously. Oxytocin, because oxytocin gets metabolized very quickly.
So oxytocin.
It doesn't remain in the system. Carbetocin remains in the system for almost 1.5 hours, 120 minutes.
Yes, correct. So side effect has to be.
Yes.
The hemodynamic effects would matter for that time.
Exactly.
Yeah, correct.
To conclude, efficacy, safety, tolerability, or one word about carbetocin.
It's a wonder drug.
Yes. We have experienced it many times. So.
And it's a lifesaver also. So rather than trying with this and that, I think we should use this and
No requirement of polypharmacy. We should
How commonly, sir, you have seen or have you seen any time failure with carbetocin?
I haven't. No.
That's
Not
very
yet.
Only thing is in few patients, yes, we have used oxytocin also
Hey, that is
as
correct.
Yeah.
Continuous IV.
In cases of PPH, one would never take a chance. We would use whatever
Exactly.
available. Yes.
Exactly.
Correct.
Yes, Priyanka, next question. I think that's all.
Uterine inertia and
Any, just go back. Any this thing you have got on embolism? I mean, any opinion you have got in uterine inertia versus carbetocin or anesthesia and massive hemorrhage, amniotic fluid embolism? Any opinion you have got on this?
I think I would tell about amniotic fluid embolism. It's very rare, but we have not seen that it increases. Carbetocin increases the
Risk
chances
of-
of amniotic fluid embolism. I have not experienced, though this is a new drug, so maybe we'll have to wait for more case studies
Experience,
and
yes.
more data. Anesthesia and massive hemorrhage. So, in GA or spinal,
Yes.
do you?
Yeah, generally in general anesthesia, the uterus is relaxed. So we need to do more uterine tonics. So in this.
So there you would like to use
Exactly,
Carbetocin
Carbetocin as the
first.
first line. And then if required, if there is even after giving Carbetocin, there is uterine tony, then we'll look after the other causes which are there for uterine tony, like trauma. If there are lacerations around genital tract lacerations, or if there is a product of placenta still inside, we'll take care of that. If we will send the blood for PTT and APTT if there is any element of consumption coagulopathy. Then after ruling out that, we can add other tonics like carbocross, isoprostol, or methergine. And then taking into account the hemodynamic stability and all, we will go ahead. But I think because of carbetocin, definitely the incidences of PPH they have come down.
That's right. Priyanka, the next one. Thank you. Thank you very much, sir. Thanks,
Yeah.
madam.
We have wrapped up the panel well
Oh,
within
it was
the time.
their lovely insights. Before I close, let me thank all the participants for their participation, taking time in this their busy schedule and attending this webinar. Thank you, marketing team Hydro, for conceptualizing and organizing this event. As you'll all agree with me, this type of program happens with excellent coordination from field. Thank you, field personnel of Hydro, for the super coordination. Last but not the least, thank you, IT team Hydro, for your support and guidance in technology-related matter. Thanks once again. Thank you, all of you, and signing off. Thank you. Wish you a very
Thank
good
you
evening,
so
sir.
much.
Good evening,
Thank
madam.
you for the inviting.
Thank you, sir.
Thank
It
you.
was a wonderful session, sir.
मस्त झालं, sir. मस्त झालं.
Thank you.